Can I move on now to Roisin Shortall, who's next?
Thanks, Chair, and I'd like to welcome you to the meeting this morning. Just to make a point in relation to comments by other members, whether the crisis is in relation to trolleys or in relation to any aspect of the health service, I mean, we know that the solution is there in terms of management and accountability, and that is the proposal to restructure the management, bringing management closer to patients within 6 regional bodies, and to underpin that with legal accountability. And I would like to think that members of government parties in particular would be more active in supporting that proposal. You know, it's all very well sounding off on a regular basis, but what we need is solutions to the whole question of the management of our health service. Okay, I just want to ask you, Mr. Mulvaney, first of all, you referred to the National Crisis Management Team. Who's on that team?
I chair as the CEO. The executive management team of the HSE is on it, and then as is the case with each crisis management team, depending on the topic, there's additional people. So the National Director of Acute Operations is on it. So the colleagues who are on the screen there, a number of our public health doctor colleagues, ambulance representatives, one of our chief officers, one of our hospital group CEOs.
Who speaks for the voluntary hospitals?
Well, who speaks for them? In this case, the actual hospital group CEO who is there is Ian Carter, who's also the CEO of Beaumont Hospital. Does that mean he officially speaks for the voluntary hospitals? But certainly he is CEO of a voluntary hospital.
Okay, and in relation to all of the hospitals then, so who speaks for them, but then who speaks to them? How do policy changes get relayed down to each of the individual hospitals?
The National Director of Acute Operations, Mary Day, who was on the Teams call, is operationally responsible for all of the hospitals, supported by the Chief Clinical Officer. So when there was a need to issue a revised clinical protocol during the current crisis in relation to management of patients of ED, that was done jointly between Dr. Henry and our operations people, and it was issued out to the system. Okay,
so in relation to the trolley crisis then, we've gone from a high of 930, I think, on one particular day, coming down to a figure of over 500, which is still completely unacceptable, and I know you agree with that yourself. But in relation to that reduction from that appalling high figure, what were the 3 main actions that were taken that resulted in a reduction in those trolley figures?
It's difficult, definitely, for us to say which of the specific actions had the most impact, and that's one of the things we're trying to make sure we can discern. Because we did a lot of additional focus in terms of leading up to the end of the week of the 3rd of January, and then we put the system on additional attendance for the Saturday and Sunday. So it's too early to say exactly which measures, because it was a range of measures. There was additional GP slots, the additional GP out of hours, the additional private nursing home beds, and there's a variety of topics. So which had the most impact is one of the things we want to try and discern as part of lessons learned.
It's concerning that you don't know which ones were likely to, and therefore the right actions to take, and then in hindsight knowing what made the biggest differences. That's a concerning thing, because that indicates just a stab in the dark.
No, definitely. It indicates, I think, and maybe colleagues want to comment, it indicates an extremely complex system and a variety. We
know it's a complex system, but we should also know what changes that, and what are the levers that impact on the numbers. So I don't know, maybe some of your colleagues might be in a position to answer that question.
I come in, Deputy. Just, I suppose we look at it in 3 strands. So the first is the emission avoidance piece, as Stephen said, increased GP access, which was rolled out as part of the winter plan, increased GP out of hours, which we saw huge numbers. We went from 22,000 GP out of hours calls to 40,000, and then 35,000 in those 2 weeks post-Christmas. Increased support for the ambulance service again, which is about emission avoidance, where we have a number of pathways in around the ambulance service where all patients don't necessarily need to go to ED if that can be preventable. So those are the emission avoidance measures that were there. The higher impact of those were around the GP piece, and then also in relation to some of the investment in what are called
Okay,
front door
okay.
services.
Sorry, I'm just time
Sure,
is tight.
Deputy, yeah.
So what are the others then?
So the other
Name
the other
two.
areas then, Deputy, would fall into the in-hospital piece
Yeah.
in terms of patient flow.
Yeah.
So that's about utilising surge capacity. It's also about focusing in terms of early discharge in the morning, so more operational processes in terms of grip in the hospital. And finally then those that facilitate early discharge in terms of the community. So that's about community beds, home care and those investments. So they're the three categories that we look at.
Okay, so
all
in
those
terms of
investments
patient
in.
flow and getting more discharges early in the morning, what impacted that most?
So what we saw is when we saw big surges in attendances and admissions during that period.
No, what impacted addressing that?
Sorry, Deputy, just say that again.
What actions that were taken addressed that most effectively?
Yeah, so there were a number of things. So utilising surge capacity, Deputy Cullinan referred to that earlier in the hospital, which allowed facilitated ward rounds in terms of hospital and community working together, particularly for elderly patients, which we saw a huge increase in through that period. And that facilitated early discharge. And then, as I mentioned, the last piece of our focus is around that community piece, which facilitates people either to go home or to various step-down facilities then and arrangements that are in place.
Okay,
around that.
and I just note that you haven't referred to the extra working hours that staff put in hospitals
Yeah, and that was that, and community.
on a
yeah.
24/7 basis,
Yeah.
or at least 7 days a week.
That was right across the board, Deputy. So that was over those 2 weekends as well as
Yeah.
one of those measures. But I suppose while that's one part of it, during that week from we had that high on the Monday and
Okay.
Tuesday, staff put in huge effort around all of those elements I mentioned to get to the point where the weekend then made a difference. So it's one part of the overall piece. It's an important part, but it was all of those levers together that made the biggest difference.
Okay, so I suppose all of that then begs the question, given that we were facing into the winter, we know that there were predictions, Dr. Fergal Hickey had said back in September that we were facing a hell on earth, or an Armageddon, I think were the two terms he used, because of what was coming down the tracks with COVID and the flu. So why were those actions that you're now saying were effective over the last 2 weeks, why were they not taken sooner?
So the winter plan, Deputy, the first thing to say, of course, it is just trying to ease pressure in the winter period. You're not addressing the core other issues that may be there in the system that deputies have referred to earlier. So it's about
No,
trying
I'm
to support
talking
through
about
that
the
period.
actions, sorry,
Yeah.
I'm talking about the actions that were taken over the last fortnight when there was, when the situation was absolutely dire and there was a lot of attention
Yeah.
on this issue. Why were those actions, which have been relatively effective, why were those actions not taken sooner?
So, deputies, some of those actions that I've identified are only possible for a short period of time. We can't expect our staff to voluntarily, provide the extra hours and so on that we talked about. GPs, again, in terms of those extra sessions, they're time-bound. Private hospital access, again, some of those measures are time-bound. So they're part of the winter plan, but they were activated at that point when we're coming into that pressure period. They're not sustainable through the entire winter, which runs, as we know, November, December, January, February, March. So will continue in terms of pressures for the next number of months. So those were activated as part of the crisis management team response at a point in time, because we know it's only going to be time-bound. We can only do them for a short period.
Okay, but arguably a lot of those actions should have been taken pre-Christmas, at least.
Deputy, sorry.
Why, was the situation allowed to get to a point where there were 930
Deputy,
people on
it's a fair
trolleys?
question that whenever you have a crisis, you'll always look back and say, should we have done something earlier,
The
sooner?
crisis didn't come out of the blue.
No, I agree. And the definition of a crisis is an important thing, because obviously we probably are too desensitised to a level of trolleys, which is unacceptable. So what we did effectively just before Christmas, as we could see from the data that things were surpassing even our worst predictions, we took additional measures which you couldn't have actually taken much sooner because you couldn't sustain them. 2 weekends was the longest for example.
Okay, but that indicates that right across the board, the health service is wholly inadequate in terms of capacity, right across the board. And that they're issues that should be dealt with and should have been dealt with years ago. I'm just going to leave it at that because I want to just move on to a few other questions. Very briefly in relation to UL Hospital Group. Why is it that it's the only hospital group in the country that doesn't have a level 3 hospital?
I'd say, Deputy, in fairness, it's the confluence of what hospitals were in place in that region and the safety or otherwise those. It's simply the nature of that region, the geography of the
Okay,
hospitals.
in my view, that doesn't make any sense whatsoever to have a hospital group without a level 3, and it is the only one. And that needs to be addressed. And Ennis is the obvious one to be upgraded. I'm just going to leave that question at that point. I want to go back to then a fundamental problem in relation to how our health service works and the complete disconnection between acute hospitals and community. And that is the fact that at any one time there's up to, around 600 delayed discharges in our hospitals. And why is it that that issue has not been addressed? It has been identified for a long time. We've had this blockage of beds for a very long time. And everybody talks about more beds. Why aren't we ensuring that there's patient flow to free up those beds? Why isn't that happening?
Yeah, so definitely, I think it's a valid question. The 600, now it's important, the more you dig into the 600, the more you realise that obviously there's a lot of movement in that, particularly in the home support
but there's
part.
600 people who shouldn't be in acute hospitals.
So we would agree, Deputy, right? And some of the measures we took was to enable all, for example, the processing to do with Fair Deal to be done in a private nursing home rather than the acute hospital, which is.
So there were delays on the part of the HSE in processing Fair Deal applications.
There's always time
what you're
to
saying?
take. No, Deputy, in fairness, if you think about it, if you look at the people who were waiting for a home, so last week I think on the 10th was 524 people, whose discharge was delayed. 220 of those were waiting for long-term care. Now, for people who went into hospital thinking they were coming out the following week, the fact that your permanent home is now going to change from wherever it was to being some nursing home somewhere is a big change for families and for the individual patients. So there was a process to be gone through with engaging with families. There are both clinical assessments and administrative forms to be done. And yes, you're right. That traditionally has happened while the patient was in the acute hospital.
Okay, so there were delays that should have been dealt with.
And now what we're doing is allowing that to happen and spending additional
okay,
resource in a private nursing home.
Okay, look, I'm going to raise the last point on that. There is a serious problem with the shortage of home care workers. Okay,
Definitely.
this was all examined, all researched, and there was a recommendation last year on that, a list of recommendations for implementation. And again, I would put it to our colleagues in government parties, why have those recommendations not been implemented? They're straightforward, they're very clear, and why are we still waiting for them to be implemented?
That's the last point, so
Right.
respond. Go on, good.
Sorry, it's a political question actually, and I'm not
I
expecting
sense
you
that,
to
yes,
answer
I
it.
thought it was the chair.
That's okay. That's okay.
Okay.
You haven't stepped into that.
You'll not respond to discussion. Okay. Grant, I'm going to move on